I am Dr. Abhijith Shetty. I am going to talk on the surgical outcome of posterior trans-facetal decompression in tubercular spondylodiscitis with neurological deficit. So basically, we all know that the spine TB accounts for 50% of all the skeletal TBs. And the basic principle in case of surgical debridement of TB relies only on minimal decompression and giving a proper stability at the end with a proper reconstruction, and so that the neural elements are free, and to correct the kyphotic deformity as much as possible, because tuberculosis is mainly a medical disease and ATT was started for all the patients. Because TB is an anterior disease primarily, so anterior approach, though it gives a good exposure to the main pathology and for decompression, but it has major drawbacks, like there is a high risk of structural damage to major organs like lungs and the pleura, the liver, the kidneys during the approach. And because the instrumentation what we do, it is already in a porotic bone which is affected by the TB, there is low mechanical stability and there is higher incidence of graft failure, and also the construct which we use for deformity correction, though it gives an initial good amount of correction in the deformity, but in the regular follow-up we see the loss of the kyphotic correction achieved because of the poor stability of the construct. So our study was mainly to evaluate a posterior trans-facetal approach and its functional, neurological and radiological outcomes for decompression tuberculous spondylodiscitis. We studied 100 patients from 2009 to 2014. It was a single institution by a single surgeon study. So it is a retrospective study from a prospectively collected data. So MRI and a percutaneous biopsy was done to all the patients for confirmation of the diagnosis, and only the diagnosed patients with tuberous spondylodiscitis with neuro-deficit of thoracic or thoracolumbar level who underwent posterior trans-facetal decompression and had a minimum 4 years of follow-up were included in the study. So we did your monthly ESR and CRP to know the progression or regression of the disease, and X-ray, MRI and CT scan were done at 3, 6 and 12 months of follow-up. So the surgical approach was take a prone position of the patient and a midline incision with the complete exposure of the entire spinous process, the lamina, till the transverse process and even till the costotransverse junction, so that the entire facet is visible, and the facetectomy was done, so through which the disc space was approached and a focal debridement was done, and the sample was sent to bacterial culture and histopathology. This is one of the case where we can typically see a paradiscal involvement which was approached by a trans-facetal fashion, and a 2-segment above and below fixation was done. Coming to the results, we operated 100 patients, out of which 86 had a thoracic involvement and 14 had TL junction involvement. So the level of fixation depended mainly on the number of vertebrae involved. Usually a single diseased vertebrae, we did a 2-segment above and 2-segment below fixation. And the mean surgical time was around 154 minutes, and we had a minimum blood loss of a mean around 155 ml. 2 patients had a dural tear intraop. In the follow-up, we had seen 86% of the patient had at least 1 grade improvement in the Frankel's neurological grading, and 16% of the patients had the neurology same as pre-op, but none of the patients had any neurological deficit post-op. In a 2-year follow-up, 94% patients had a good fusion rate according to Bridwell's criteria, and the mean fusion time was around 6 months. The pain parameters also drastically improved pre-op and post-op with the VAS score from 6.5 to 1.73 and ODI and 76.54 to 30.5. And the kyphotic angle, there was a very good correction pre-op from 22 degrees to 5.14 degrees, which was very well maintained in 2 to 4 years follow-up. So concluding the topic, the posterior trans-facetal approach is a very reliable, safe and effective approach for tubercular spondylodiscitis debridement, where it gives adequate exposure not only for debriding the spondylodiscitis area and also for the paraspinal abscess draining, and to achieve a good circumferential decompression and good kyphotic correction, which is even well maintained in the follow-up, because the screws or the implants what we give, they are placed in the strongest part of the vertebra, that is the pedicles. So the chance of loss of kyphotic correction obtained during surgery is very less in the posterior trans-facetal approach. Thank you.